Coker is a healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape.
Welcome back to another episode of Coffee with Coker. And on today's episode, we are talking to Jeannie Cagle, who has been on the podcast before, and she's one of our team members that's been around for many years. And Jeannie's specialty is coding. And coding, she does a lot of our coding audits, coding and compliance, coding training, etc. And we thought it makes sense that we talk about almost taking a step back and get back to the basics of coding, if you will. And so that's what we're doing. We're talking about coding basics. And I think this is helpful just simply because we get a lot of questions on this topic. We do a lot of work around coding, but just kind of understanding what does that mean when we talk about not just what coding is, but what are the best practices around coding? What are some of the pitfalls around coding? What are some of the risk areas? And then what is, why do we need an audit? Who needs audits? What does an audit entail? We get a little bit into that, and we have a lot of other content that goes deeper into that. And obviously Jeannie can speak more to that if people do have more specific questions. I know she's written a white paper, and we'll make sure it's available on the coding audit process and again, other things related to coding and compliance. So, this is kind of a quick discussion with Jeannie, and obviously we can go into more detail on some of the things if anyone has questions, whether it's specific to their organization or if there's just stuff they would like to learn more about on this or related to this topic. Jeannie's great. She brings both a business and clinical perspective. She's a RN, and so I think that's given her a lot of unique experience in terms of working with clients on both the education front as well as working through the audit process and interpreting those results. So we hope you enjoy this conversation with Jeannie. If you have questions or you'd like more information on this or anything we cover on the podcast, don't hesitate to reach out to us. You can find this episode along with all of our Coffee with Coker episodes on the website at coffeewithcoker.com. You can also find them via the main Coker website at cokergroup.com. And with that, if you have any suggestions on future topics you'd like us to cover on episodes, don't hesitate to let us know on those as well. But other than that, we hope you enjoy this conversation with Jeannie Cagle on coding basics. Thanks for listening. All right. Well, welcome back to the podcast. And as we mentioned, we have one of our recurring guests that we've had in the past, but welcome, Jeannie Cagle.
Thank you, Mark.
And today, as we said in the intro, we're talking about coding basics. And, this is one of those things I know we get questions on because obviously Coker does a lot of work in the coding realm, and Jeannie has been doing that work for a number of years. And a lot of people that are involved with the ins and outs of coding day to day in their job understand what this is. But there's a lot of folks out there that, coding is kind of this elusive thing. They understand in general what it is, but the ins and outs of it are still a mystery. And so we routinely go, and I say we, Jeannie really goes and will present to organizations on this topic. What do we do around coding? Why is it important? So we thought it'd be good, Jeannie, just to have a quick discussion around what are the basics of coding. So I guess, as we jump right in, maybe just start with, if someone says, give me the rundown, what are the key codes that are important? What are the key concepts that you would say in terms of articulating the bare bone basics of coding?
Okay, great. So when we talk about professional coding, when you think about what a physician does or any provider would do in their day in and day out work, there are actually two code sets that are the basis for them all. The first is the CPT codes. These codes were written by the AMA. There are about 10,000 codes in this code set, and it's a 5-digit number, but pretty much it describes what was done. What did the provider do? Was it an office visit? Did they do a procedure? Did they do a surgery? And that 5-digit code is a description of what was done. The second set of codes are the ICD-10 codes, and these are actually based from the World Health Organization. They're known as diagnosis codes, and believe it or not, there are about 68,000 to choose from. These are 7-digit codes, and they pretty much describe why you did it. So really, bottom line, coding is using numbers to tell a story. You're using one set of numbers to say what you did and another set of numbers to say why you did it. What was the diagnosis or the problem that made you do what you did? If you think about it, it's actually a fairly clever system because you can imagine how difficult it would be to communicate this otherwise, but yet those sets of numbers on a claim will pretty much say what happened that day. And there has been given to those CPT codes, there has been given a value or something that says this is worth this much money. And that's how it's interpreted into billing. Now, it's important to say that nobody is smart enough to know all the codes all the time. Coders and billers tend to have a lane or an expertise within this massive set of codes. So, for example, my world or my lane are E&M codes, which are office visits, hospital visits, pretty much the bulk of billing. But if you were to have me look at interventional cardiology procedure notes when you do a heart cath, I would not have the expertise to understand those codes. So there tends to be specialization within each of these code sets. Kind of like you would never want a dermatologist to deliver your baby. You want to be sure that you have the right person who understands that particular set of codes. So that's just kind of the basic principle. You're using two sets of numbers to tell a story.
Yeah, well, that's helpful, and I guess from a bare bones functionality perspective, as you said, no one is going to be able to remember every single code, but it standardizes and provides some consistency to what you're doing. So, if it's a 99213 or whatever, and you can kind of look at those as far as what's reflected in the system. And then there's notes attached to it as well. And then of course that can vary, from the very basic like that to some obscure code that has maybe even, not that we have to get into this today, but modifiers to it and things like that. But at the end of the day, it all equates back, and you made this point, and I think it's good to point out that it all equates back to value. So we can measure the value of those units and those codes entered and the volume of those, tie that back to an actual clinician's production. Is that correct?
That's right. That's exactly right. And so to your point, an office visit for a convenient care provider who sees someone for a bad cold will have a lesser value attached than an oncologist seeing a patient on the day that they're preparing a chemotherapy regime.
Sure.
And so those different levels of codes reflect that complexity for the patient's condition, and it also reflects the amount of work, cognitive work, and oftentimes how much time is spent for that particular service. So once again, those numbers would reflect the differences between those two.
Okay, gotcha. Well, you mentioned the ICD-10 kind of being linked to the World Health Organization, but talk about maybe what are some of the other, what are the sources that are out there that are, I guess, considered gospel, or kind of the main sources driving the actual codes, and then I guess the practices of coding behind it?
Okay, so that's a great question. We have the CPT codes and we have the ICD-10. Now, most of the time you'll hear in the news, or there's a lot of emphasis on Medicare and Medicaid, government payers. And yes, they are, a lot of the money spent in healthcare is spent by Medicare. So let's take Medicare, for example. They generally work within the CPT AMA guidelines. But what they also do is interpret things with their own twist. So they have published like the Medicare Carrier Manual. It's very important to know you may have a CPT code and you start with that with the AMA codes, but then you need to go to the Medicare Carrier Manual and see if they have perhaps a different interpretation, or if perhaps they've even created some of their own subsets. Let me give you an example. For someone who is not a Medicare patient, when they go see a physician for a preventive medicine service, like their annual physical, they're not sick, they're just doing their annual physical, There are a set of codes in a CPT book they would use for that, whereas Medicare has a separate G code, G0438, for the annual wellness visit for a Medicare patient, and they are not the same.
Mm.
So if you were to use the 99397 for a 65-year and older patient, for a Medicare patient, it's going to be denied by Medicare because they're going to say, no, we have a separate set of codes and we have a separate list of things we want you to do, and it's a G code. So, once you get the basics down, then you need to dig a little deeper if you've got Medicare patients, Medicaid as well, and see if perhaps there are some nuances there. One more thing to add, another tiny caveat there is each state has a separate Medicare administrative contractor. So, for example, the state of Georgia has Palmetto. So even Palmetto may have a different set of interpretations of Medicare's code than perhaps Texas or New Mexico, where they would have Novitas or Noridian or another MAC. So it's one of those things where once you find out for your particular practice or group of practice, while this sounds overwhelming, you're still only learning a subset for your particular provider. You just have to be diligent and look these up and kind of understand.
Well, that's incredibly, it seems incredibly or potentially incredibly complex. And that, like you said, if you're just one group in a single state, probably you can figure out your system that you need. And even then, I imagine it changes and fluctuates year to year or whatever, every few years.
Yeah.
And so you have to stay on top of that. But then if you're a health system and you have hospitals and clinics and practices and physicians in different regions, let's say, I mean, at some point you're going to have to be on top of all that. And you have all the commercial payer contracts as well that have to tie in and have their own documentation requirements and those types of things. So it seems like there could be almost an endless amount of layers here.
Yes. And to your point, you just mentioned commercial insurances. That goes according to the contract. And so you can imagine, like you said, if you've got more than one state, you have these multiple contracts. So you may have a different setup with Aetna than you do with Blue Cross Blue Shield for different sorts of things. And so all of these are things, not only do you have to make sure you understand those nuances, but then as things change, you have to update your understanding.
Well, I have to think, and you're an RN, and I have to think there is some value there being you having that clinical experience, which a number of the folks on our team that work within coding also have, and not everybody has to have it. And I don't think that's a requirement, but I guess my question is, does that help you when you're going in and working with organizations on either improving, optimizing their coding practices, or maybe looking at it from the other perspective of more of an audit, a risk assessment, that type of perspective? Does that ever your clinical experience ever play into that process?
Yes, you're right. It's not at all a requirement, but it certainly is beneficial, probably most often in having conversations with providers, with physicians and nurse practitioners and PAs, because Medicare, CPT, everyone, and in fact, Medicare is shifting in the next couple of years to be even more this way, is medical necessity, or how sick is this patient, is becoming more and more overarching versus do you have the technical components that go with a note. So now that we have electronic medical records, it's fairly easy to have a very comprehensive note because you're not handwriting it, right? You're not tired. You're clicking. Your hand's not cramped. You're clicking things and putting all kinds of data. But the question is, how sick is this patient today? So those conversations, sometimes coders without a clinical background are a little tentative, although they do a great job of understanding, look, all I know is this is what you need to pass muster. And they can be helpful, in that communication. The other thing to keep in mind is while audits and ongoing reviews look note by note, all insurance carriers, commercial, Medicare, Medicaid, everybody is constantly data mining and watching billing patterns of physicians. So they're looking for outliers. Anything you do billing-wise that makes you different than the norm. And it doesn't mean you can't be different. It just means if you are, you need to be able to explain why.
Sure. Yeah.
So, everyone says, well, we've never had an audit, so I'm not worried. And boy, there's a lot of docs. But the truth is they're constantly data mining. And often that's what brings a particular physician's name on the radar, is just because they bill very differently.
Well, that's a really good segue, because that actually brings up where I wanted to go next. And we talked about the basics of coding. What is coding? But really, what it ties back to is, at least from our perspective, what Coker does. A number of different things related to coding, but I think one of the biggest things is that coding audit. You and others here, we've written some white papers. We have a lot of content out there people can find on our website as it relates to coding practices and coding audits. But maybe just walk through that, because at the end of the day, I think what you just referenced is very common, in that they're either not expecting to be audited, or, I think most physicians, most clinicians do their job well, do what they were trained to do well. But not only do you have to do that job, you have to document those things. Like you said, it may not be bad that you're an outlier. You just want to make sure you can explain, hey, here's why we did it this way, or these are our practice. So that ties back to the audits. Maybe just give us a high level overview. What is the audit? And then maybe talk about some of the nuances there that others may not be as familiar with when it comes to audits.
Sure. So first of all, the thing that we understand in the world of medicine is it's so much smarter to be proactive versus reactive. And so a robust compliance plan within any group, whether it's large or small, it just makes sense. You're looking ahead of time to see how things look, how things are going. You can run your own data comparisons to national averages. They're published everywhere, and see if your physicians are outliers. And then also take a sample of notes. I call it Name That Tune. I don't know if y'all remember that old TV show, but pretty much in a few notes, you can tell what a physician's pattern is. You can tell the template they typically use. You can see where the strengths and weaknesses are in a note. You don't necessarily have to do hundreds of notes per doc. You can actually do a sampling and get an idea of their strengths and weaknesses. One of the things that we run into everywhere we go, and that is, and this is legitimate, but most all physicians and APP went into their careers with a goal of caring for patients. And the business side is just a real hassle. So, anytime you can create a culture in your practice of saying, listen, we don't want you to become coders, and we don't want you to become the CFO or the business person or any of that. We want to give you everything we can to help you succeed. But the bottom line is their NPI, their provider number, is on that claim. It's kind of like when you sign your tax return, you're counting on that accountant, but it's still your tax return. Same thing for a physician claim. So it's one thing to do an audit, but you've got to let the doc know, here's how it looks. Here's what you need to know, giving them education, giving them the resources, make it easy for them, make them feel supported, give them a place where they can ask questions. They don't know what they don't know, but presenting it in a way where they feel encouraged versus harassed, because they've got a lot of pressures on them. That's really, our goal when we approach an audit. It's one thing to get your information, but it's another thing to support your physicians.
Yeah. And I guess, at the end of the day, like you said, we don't need them to be coders and to understand all the ins and outs of every element of, the way their organization functions. But this can be something that helps them do what we need them to do, which is deliver that clinical care even better, more efficiently, more accurate, more well documented, whatever that may be. Because, if there are issues, then that's only going to create more things for them, more hassle for them to have to deal with.
That's right. That's exactly right.
When you're going in and doing these audits and working with organizations on whether it's auditing or looking at optimization opportunities, improvement, whatever. What do you typically see as the most common problem areas, if you will?
Oh boy. I would say actually there's a few things that we see. One is what I call coding folklore. So someone has a general principle that's true about coding, but then it's morphed over time as it's been communicated between non-coding people. So I'll give you an example. Recently, I was in a huge internal medicine group, and as I looked at their notes and was doing an audit, the annual wellness visit that I referred to a while ago from Medicare, there are 11 specific things that need to take place within that audit. For example, you do a depression screen and you do a fall risk analysis and you do some things because they're being proactive about Medicare patients. Well, these folks they had gotten those guidelines, but they had interpreted them as it made sense to them as to what that meant as far as how to document it. So they were about 48% of the way there, but they were missing the other 52%. So if they were to be audited, Medicare would want all that money back. But they were being diligent and they were really trying to do it well. They just hadn't asked the right people. So those are things that an audit can be really helpful, particularly somebody from the outside who doesn't know who wrote it, who's going to get their feelings hurt, who's going to be blamed. None of that. You're just looking at the notes and will this pass muster? The second thing we see often are not keeping up with changes. Things do get updated from time to time. There are new services that come out. There are things that are no longer covered. There are lots of resources online where once a year, those things are actually outlined in one place. These are the changes for this year. So someone has to be diligent to be on top of that. There are big changes to office visits coming in 2021, and CMS or Medicare has actually agreed with the AMA, where we're all just like, well, I saw a pig fly by. I mean, that rarely happens. But that's good news, but you need to know what those changes are so that you're ready to go.
Yeah, I have to think that goes the other way too, right? Because again, this probably doesn't happen as much as we'd like, but occasionally the system, as it were, will kind of keep up with new trends. And I'm thinking, and I know we've spoken on this before, but things like telehealth and trying to keep up with, or evolve and update our coding practices to do new things and to be able to capture the value of those services on new things like telehealth.
Oh, listen, telehealth is a great example because went into practice a couple of months ago and they had heard telehealth and they'd read a couple of things, and guess what? All phone calls to the practice, they were sending out bills. Okay. That's not telehealth. That's what I'm saying. Wow. That, that'd be awesome. But those aren't what the guidelines say. And so,
yeah. And well, I don't mean to laugh at them but I think that's a great example of, okay, there is this new thing, whoever it is, CMS or whoever it may be, whatever entity, is releasing maybe it's guidance, maybe it's commentary, maybe it's a full on new law or it's legislation working to be law. But okay, what does that mean? How do we now start capturing production and value around telehealth visits? What does that need to look like?
That's exactly right. And the thing is, you'll miss out on some like transitional care management. When those codes first came out, the whole intent is to pay a physician a lump sum fee for the first month after a patient has been discharged from the hospital. It's great because usually that's time intensive for a practice and they've not been compensated for that to date. But a lot of folks don't realize you have to make a phone call to the patient within 2 days of discharge. You've got to go over their medications with them, make sure they have the resources they need, make an appointment for them to follow up with the doctor within 7 to 14 days. So those are specific details. And hey, let's get that rhythm going in your practice. Let's assign some people to take on that role because the reimbursement's great, but you got to follow the specific pieces of that in order to bill for it. So it's such a balance.
Mm-hmm.
And I very passionately, all of us at Coker, but we very passionately believe with the right resources and the right information and a great electronic health record, you can set up a rhythm to capture these things and then take care of your patients. Don't feel like you have to look over your shoulder every minute, but set it up and then do what you do best, and that's take care of your patients.
No, that's exactly right. I mean, I think that's very well said, and there is value out there that can be captured, and I think that's going to continue to evolve, hopefully, and there'll be new sources, new pathways of value continue to develop and emerge for clinicians, and they don't need to be afraid to pursue those. But it may be a very relatively basic, straightforward effort to kind of set a good foundation, and then from there, you can go after that value all you want.
Absolutely, yes. And then you can feel confident if they say, "Hey, send us some records. We want to take a look." You're like, "Great, take a look. It looks great." We're confident in that.
And then if some entity ever did come in asking questions, whether it's a full-on audit or maybe it's just something, like you said, kind of a little outlier popped up on some radar somewhere. Well, okay, look, we went through this practice. We went through this effort. We did this education programs. We implemented these protocols, and it's a part of our compliance program, et cetera, et cetera. And, I think people accept there's going to be kind of some things slip through the cracks along the way, maybe some minor mistakes along the way. But if the overall system is there, I think they're a lot more willing to look at, okay, they're not trying to commit fraud or do anything very blatant, but hey, we can work with you now.
Absolutely. If you have a compliance plan in place, you're following it to the best of your ability. You're exactly right. That is as much stronger defense. And the thing is, there's a lot of press for when you find the fraudulent doc who was, billing for people who had died or whatever crazy thing. You see that all the time.
Sure.
But there are often audits that the practice passes with flying colors, and that's the end of that. So not every time there's an audit does everybody get in big trouble.
That's right. Well, Jeannie, this has been really helpful. And I know, again, there's tons of questions out there as it relates to coding. So I know some of the people listening and people that find our content out there, I'm sure have their own questions and very specific, probably questions where they could benefit from you. So we'll make sure obviously all your information is going to be with the show notes, and we'll provide any supporting content as well. But I really want to encourage everyone to feel free to reach out to Jeannie if you have any of these questions. She's a great resource. So I appreciate you talking about this.
Sure. No, I'd be delighted to answer any questions or help any way that we can.
Great. Well, thank you, Jeannie.
Okay.